This conference will now be recorded.
చేసావు చేసావు అది చేసావు ఏదే ఉండదు నీ కొడుకు అన్నీ మీకు అప్పుడు పెట్టలేదుగా పెట్టలేదేను మమ్మీ ఇక్కడ మ్యూట్ ఆఫ్ లో లేకపోతే అదే
చెప్పానా? Good morning. Today we are going to discuss about two tumor-like conditions. They are not exactly tumors. The simple bone cyst. Am I audible? Okay, the simple bone cyst. Yeah. Okay. And aneurysmal bone cyst. Coming to simple bone cyst, this is also known as unicameral bone cyst. This is a non-neoplastic serum fluid-filled bone lesion. So this is not a bone tumor as such. This is a bone lesion. It's thought to be the result of temporary failure of medullary bone formation near the physis, usually seen in males less than 20 years. So this is a childhood condition. This arises in metaphysis adjacent to physis and progresses towards the diaphysis with the bone growth. As all the tumors are common in proximal humerus, proximal femur, distal tibia, ilium, and calcaneus, this is also common in the same sites. Occasionally, it can be seen in metacarpal phalanges and distal radius. These are mostly asymptomatic unless fracture occurs usually within the minor trauma. May also be present with pain as a result of pathological fracture. So most of the time this is asymptomatic unless there is a trauma or pathological fracture. So how do you investigate? Because there won't be any symptoms, you'll have to depend upon the investigations. The main key investigation is X-ray. In X-ray, you might see a central light, well demarcated metaphyseal lesion. In this, you will see this is a well demarcated metaphyseal lesion and cystic expansion with symmetric thinning of cortex. And the pathognomic sign is fallen leaf sign. You see, this is a bone fragment in the cavity that is known as fallen leaf sign. This is a pathognomic and pathological fracture with fallen cortical fragment in the base of the empty cyst. This is why that is known as fallen leaf sign. Trabeculated appearance after multiple fractures. If you have multiple fractures, we can see trabeculated appearance. Then coming to CT scan, little to diagnosis but are helpful in differentiating other conditions which may mimic simple bone cyst. So the mainstay of investigation is X-ray. Differential diagnosis. Coming to differential diagnosis, you will have to differentiate this from aneurysmal bone cyst, intraosseous lipoma, giant cell tumor, fibrous dysplasia, non-ossifying fibroma, and eosinophilic granuloma. Treatment. Coming to treatment, we will have an operative and non-operative. If the patient doesn't have any pathological fracture, if this is an incidental finding, then you go with immobilization and non-operative treatment. Or you can go with the immobilization if the pathological fracture is less than 50%, 15% involvement of the native. Aspiration and methylprednisolone injection can be given. This is in the active cyst. Operative treatment is curating and bone grafting is mainstay of operative treatment. If the lesion is involving more than 15% of the bone, then you'll have to go for operative treatment. This is based upon the tumor location. Indications: proximal femoral lesions with pathological fracture due to high rate of refracture and malunion when treated non-operatively, and symptomatic latent cyst unresponsive to steroid injections. First try a non-operative method, then go for the operative method. And latent cyst in proximal femur that are structural concern and at risk of fracture and osteonecrosis. Contraindication: this should be avoided in active lesion, communication with physis, which may lead to growth arrest. Okay, simple bone cyst. We'll revise once again. This is a tumor-like condition, more commonly seen in males less than 20 years of age, more commonly seen in metaphysis, in proximal humerus, proximal femur, distal tibia, calcaneum. Asymptomatic generally. You can see a fallen leaf sign and well-demarcated central lytic lesion. CT scan adds little. Differential diagnosis: aneurysmal bone cyst, GCT, interosseous lysolioma, non-ossifying fibroma. Treatment: non-operative if less than 15% is involved. Steroid injections. Operative majority of bone is involved. Okay. Aneurysmal bone cyst. This is another type of bone cyst. This is more drastic and more dreadful than simple bone cyst. Aneurysmal bone cyst is a locally destructive and blood-filled reactive lesion of the bone. This is locally destructive, though this is not a malignant lesion, but this is locally destructive. That is why we need to be more cautious about this. It arises spontaneously or after degeneration of hemorrhage in some other lesion. So this can be a secondary aneurysmal bone cyst also. Sites involved: any bone may be involved, but more common in proximal humerus, distal femur, proximal tibia, and spine. This is one of the tumor which is more common in spine. Spine has very limited number of tumors, so we will have to remember this tumor. Vertebral lesions: 15 to 20% is located in posterior elements. Posterior elements with extension into vertebral body to adjacent levels. This is also more common in less than 20 years, but this is more common in female preponderance. Mild to moderate pain. Compared to simple bone cyst, which is asymptomatic, this has a mild pain. Rapid growth and clinically mimics malignancy. Spinal lesions may cause neurological deficits or radicular pain. So this is an expansile lytic lesion coming to radiology, which elevates the periosteum but remains contained by a thin shell of cortical bone. This you have seen simple bone cyst which is centrally located, but this is an eccentric expansile lesion. This has a well-defined margins or a permeative appearance that mimics malignancy. Bone scan is one of the confirmatory diagnostic tests. Shows a diffuse peripheral tracer uptake with a central area of decreased uptake. You see here in the first picture, central area is little lesser darker than the peripheral area. This is known as Downett sign. CT scan is helpful in areas of complex anatomy such as spine and pelvis. Thin rim of bone surrounding the cyst can be identified. MRI, multiple oculated cavities and fluid levels can be seen. And double density fluid level and intralesional septations usually indicate an aneurysmal bone cyst. Double density fluid levels and intralesional septations. Differential diagnosis: GCT. Again, a simple bone cyst is a differential diagnosis of this. Osteoblastoma, chondroblastoma, non-ossifying fibroma. Treatment: we don't have a non-operative treatment in aneurysmal bone cyst. Coming to surgical treatment: extended curettage, grafting with bone graft substituent. In bones which permit it, marginal resection can be done. Spine or pelvis: preoperative embolization to minimize blood loss. Arterial embolization used as a definitive treatment in location where curettage is extremely difficult. Recurrence rate is 10 to 20%. Recurrence correlation, if the lesion is less than 15 years, you'll have more recurrence, centrally located lesions, incomplete removal of cystic cavity contents. Recurrent cysts should be treated as a primary cyst. Coming to aneurysmal bone cysts again, this is a tumor-like condition, but it's locally destructive. It's spontaneous in occurrence, or it can be a secondary tumor. It is more common in proximal femurs, distal femur, proximal tibia, spine. More common in females in less than 20 years. Mild to moderate pain. If it is a rapidly growing tumor, you will have to suspect a malignancy. Spinal lesions cause neurological deficits. X-ray is an expansor lytic lesion which elevates the periosteum. Bone scan, you'll have Downert sign. CT scan is more useful when you have a complex anatomy or deep-seated structures like pelvis. MRI, you see double density fluid levels and multiple septations. Differential diagnosis of GCT, simple bone cyst, chondroblastoma, osteoblastoma. You don't have non-surgical treatment. Coming to surgical treatment, that is marginal resection, curettage and grafting, preoperative embolization, arterial embolization. Recurrence is common. You'll have to suspect recurrence if the age is less than 15 years, centrally located cyst, or incomplete removal of cystic cavities. Thank you. Does anyone have any doubts?
No, ma'am.